Welcome to AETCM, the Emergency Medicine Channel. Today I am presenting a case of 56-year-old female presented to ER with complaints of fever, headache and myalgia since 2 days. On initial 10-second assessment, airway was patent, no pooling of secretions, breathing respiratory rate was 16 per minute, saturation was 95% in room air, circulation BP was 130/70 millimeters of mercury, pulse rate was 88 per minute, all peripheral pulsations equally felt. Coming to disability, GCS was 15/15, pupils equal reacting to light bilaterally, and she was afebrile. Coming to history, 56-year-old female who is a non-case of systemic sclerosis, status post thyroidectomy, presented to ER with complaints of fever, headache and myalgia since 2 to 3 days. There was no history of any upper respiratory symptoms, cough, shortness of breath, abdominal pain or dysuria. She was seen in a local hospital and was found to have dengue NS1 positive and was referred here with thrombocytopenia. There is no history of any bleeding manifestations at the time of presentation. So she was on regular medications of steroids, tab omnacortal 5 mg OD and methotrexate 10 mg on night once weekly, and folimac 5 mg OD and moficon 500 mg BD, thyronome 125 microgram and rosuvas. And initially on initial investigations, the platelet was found to have 74,000. So we stopped the methotrexate and MMF in view of thrombocytopenia. And on regular means
will they produce thrombocytopenia, MMF and methotrexate?
Because it can cause pancytopenia, bone marrow suppression. So already she is in viral infection with bone marrow suppression, so we stopped the medications.
Right. Normally it will not produce. MMF will never produce. It can produce in an acute phase, but normally it will not produce. Even methotrexate also will not produce thrombocytopenia and low counts when there is an infection. It as such can produce sometimes. Even if you don't stop it, there will not be any problem.
On routine blood investigations, her calcium, serum total calcium was 5.46 milligram per deciliter with albumin of 4.2 and magnesium of 1.8 and phosphate of 6.1. So actually she was not at all, when detailed questioning, she was simply having some tingling sensation.
Okay.
And her thyroidectomy was done in 1997 and she was asymptomatic. No features of hypocalcemia was there at that time also.
Okay. What is the importance of albumin and magnesium in these patients?
Hypoalbuminemia, the calcium in the body is like 1% is in the blood and 99% will be in the bone, and that 1%, 50% will be ionized, and 40 to 45 will be bound to albumin, and another 10 to 15 will be bound to phosphate lactates anions. So if there is hypoalbuminemia, there will be pseudo-hypocalcemia.
Okay. Magnesium?
Magnesium will also cause the decrease, means the sensitivity is
sensitivity of
the calcium absorption.
What is the action of magnesium in calcium metabolism? It is useful in action of the parathyroid hormone. It will become ineffective. It will not directly involve your calcium or this one, but it affects the PTH levels. Okay.
With normal albumin, the calcium was found to be low, and with on investigation also, the parathyroid hormone was found to be low, 6.86, and ECG was not showing any QT prolongation. Initially we had started on since it was 5.46 and she was complaining, when detailed questioning she was complaining some tinkling over the fingers.
Okay.
So we started on calcium gluconate initially 10% 10 ml over 10 minutes, and all started on a infusion also, but after 12 hours when we checked calcium, it was only by 6.56. So we had given an endocrine consultation since she is a case of systemic sclerosis and suspecting hypercalcemia secondary to hypoparathyroidism due to probable autoimmune. So they have
what is the PTH level?
PTH level of 6.86.
So that is low.
Less. They started on oral supplements only of calcium and Rocal, that is cholecalcitriol. Calcium 500 mg 5 times daily was given with along with 3 meals and 2 snacks.
Okay.
And then Rocal 0.25 microgram 2 BD was started.
Okay.
And gradually the routine means gradual monitoring this calcium was normal, became normal.
What are the emergency requirement of a IV calcium infusion?
IV calcium is emergency required if there is carpopedal spasm, any tetany, any seizures, any bronchospasm, or any stridor.
Anything else? ECG changes. Okay. These
If
are
there
the
is
important things you have to give IV calcium. Otherwise, it will increase the calcium, but it is not really indicated. But you can give calcium if the patient is having symptomatic hypocalcemia. Okay. Does this patient had any ECG changes?
No, sir. There was no QTC prolongation, no arrhythmias was there. Since we found it was very low, we just started.
Okay.
So usually, if there is hypocalcemia, first we have to find out the albumin levels. We have to actually we have to find out the corrected calcium. So the serum calcium, corrected calcium will be serum calcium plus 4 minus albumin into 0.8.
Okay.
If there is causes for hypocalcemia, if there is hypoalbuminemia or hypomagnesemia, we have to correct initially this thing. And the management is like if there is any symptoms of acute hypercalcemia like carpopedal spasm, any stridor, any tetany, any seizures, any ECG changes, the IV calcium is indicated. If it is there is no whether it is asymptomatic or mildly symptomatic acute hypocalcemia, that is the calcium level should be less than 7.5 or ionized calcium less than 0.8. And if it is there, we can give IV calcium. If there is the calcium level is more than 7.5 or more than 0.8, ionized calcium is more than 0.8, or if there is no, it is not an acute hypocalcemia.
We are not directly doing ionized calcium. Our ABG value
will be showing.
That may be showing.
Or if there is asymptomatic or mildly symptomatic chronic hypocalcemia, oral correction can be given. So if she is able to take oral correction, we can give oral correction, or if she is not able, then we can give IV correction. If there is, we are giving IV calcium.
She is on taking steroids. What will happen to calcium levels when you are taking steroids?
There will be bone resorption.
Bone resorption and?
Hypercalcemia.
What else? Bone resorption is one problem. Other problem is absorption will be reduced. So two ways the drug what she is taking also can prevent, can aggravate the hypocalcemia, because bone resorption is increased and the absorption of calcium is reduced. This is the same thing we treat hypercalcemia, we give steroids. Okay, so that is a problem in this patient.
So if we are giving IV calcium, the calcium monitoring should be every 4 to 6 hours, and magnesium, replete magnesium if there is hypomagnesemia. If you are giving oral correction, if it is acute hypercalcemia, every 12 hours we have to check for the calcium. If it is chronic, once weekly we can. If after oral correction, if the calcium is coming to normal, continue the oral correction, or if it is still less, increase by every 1 to 2 gram daily of the calcium supplement.
Up to 4 grams you can give.
To 4 grams.
So what are the basic investigation you do in this type of patients?
If there is hypercalcemia, first initially LFT,
albumin is done. Then second one is?
Then vitamin D.
Vitamin D is one of the things.
Then parathyroid hormone. Then for correction, we have to check for other regulators, so magnesium and phosphorus. In primary hypoparathyroidism, that is a condition you are dealing with. What will happen to all these elements? What will happen to calcium? What will happen to phosphorus? What will happen to PTH? What will happen to magnesium? Everything will be reduced, because primary hypoparathyroidism is
calcium is reduced.
Parathyroid
is reduced. Phosphorus is reduced or normal or increased?
Normal.
It can be normal or increased, slightly increased. It is not reduced. This one?
Secondary hyperparathyroidism.
This is primary. We are dealing with primary. Secondary it is different. And magnesium? Magnesium can be normal, but if the magnesium deficiency is producing hypoparathyroidism like feature, then it will be definitely reduced. So all this basic investigation you have to do. Should we do some X-rays or something in this patient?
To rotary bond resorption.
Anything
In the
is to be done on an X-ray of abdomen. Anything is required or not? I'm asking you. Should we do any investigation, further investigation or not?
since
Hypercalcemia require all this investigation. Hypocalcemia normally we don't do any investigation. Only basic blood test will be enough, and you need to correct this one. Okay, only if symptomatic patients we need to give IV correction. Otherwise, oral will be enough. But the only problem is very high dose will be required for most of the patients. What happened to the patient afterwards?
she was
Dengue. What happened?
dengue, gradually the platelets was improved, and she was asymptomatic. No, there were no fever spikes, there were no bleeding manifestations, and with time, with 4 days, she was admitted here, and platelets was improved. And this with oral, the supplements also calcium also improved on discharge. She was having the calcium of 9.59.
If dengue is not there, scleroderma patient coming with severe muscle pain, what will you suspect? What would you suspect? Dengue is not there. Patient is having severe muscle pain. She is a non-case of scleroderma. What will you suspect?
Hypocalcemia.
Hypercalcemia will produce weakness, but muscle pain will not be there. Scleroderma. What is that condition? Polymyositis. Polymyositis is one condition very commonly associated with scleroderma. They come with severe muscle pain, especially proximal muscle. Their CK will be very high. So here it is dengue fever, so no need to worry about that. Platelet, normal.
No, initially it was 74,000.
Now it is improved.
Then it was improved.
So no, actually no need to stop the drug at all. You can still continue the drug. If it is dropping very low, then you can probably hold it. Okay. When MMF is a drug of choice in ITP, so that also can be continued. Okay. Anything else? Okay. Thank you.